So you've talked and touched upon a lot of the responsibilities for the APP, not only in terms of helping make a diagnosis and coming up with a treatment plan, assessing the toxicities, setting what the toxicities will be and assessing toxicities, and then really marshaling the plan through and following the patients through the treatment continuum. And it's quite a responsibility to have this role. And given the responsibility, maybe you can touch upon the biggest challenges you think APPs like yourself face, and you in particular face, when managing patients with lung cancer, or any cancer for that matter.
So I'll say, in particularly to me, the challenges that I have is overwhelming, right? As exciting lung cancer is just as overwhelming, right? And knowing the knowledge and wanting to know what's coming out new and how to understand that and how to articulate that to the patients when they ask questions, that sometimes can be stressful in itself, right? And so that's one of the biggest things for me, right? The second,
keeping up with the data.
Keeping up with the data, exactly. Communication. Though I think I do a great job, I'm always challenged to think I could do more, right? You know, I put myself in the place of a patient or a caregiver that's calling and the need to follow up, right? And the need to bring them and address them. I think I do a great job with it, but I think there's always room for growth.
I think all of us have that
And then
challenge.
lastly, I think, not necessarily for me, but in general, one of the ongoing themes with APP is the collaboration with physician. It's so important for an APP to feel part of the team, to have that respect with the physician that they're working with, and vice versa, and knowing that you can come and ask questions and they are wanting to teach you about, you know, what the disease is, what the new study is, and still knowing that you have to take the onus on yourself to educate yourself, but that collaboration is key, you know, and I think that's one of the reasons why I enjoy working where I work at, is because I think we do that very well.
And I think you hit upon every challenge that physicians face, which is collaboration, communication, and keeping up with the data. It just tells you, I think we work together as a team. There's not some sort of hierarchy. We are delivering care, and we each kind of face the same challenges and trying to make the patient, or at least get the best plan available for the patient. But that means keeping up with the data, collaborating and communicating, and that's what the whole purpose of a team is. So I think you've really touched nicely on the challenges that I think we all face. Well, Rasheda, thank you for coming on and really layering in your own unique perspective from an APP.
I appreciate it. Thank you.
So we talked in the last few segments about the importance of the interventional pulmonologist and the pathologist in making a diagnosis. That first step where we need to procure enough tissue, and then the tissue journey of mutational testing and additional testing, whether it be PD-L1 or potentially tumor mutation burden. But it's important to recognize that the pulmonologist and the pathologist do stay relevant along the treatment continuum, each of you, even after diagnosis is made. So Andrea, can you talk about some of the things that you bring to the table or may still be involved in for a patient who's already started treatment?
Yes, I think that's one of the benefits of having a comprehensive cancer center where you have a lot of different facets in one area, because I like to think as an interventional pulmonologist or even a pulmonologist after making the diagnosis, I still follow very closely along with the patient after treatment and as they move forward. And a lot of times these are playing the role of a pulmonologist and interventional pulmonologist with regards to complications that arise from the tumor itself or even the treatment of the cancer itself with regards to the lungs. So one example would be if oftentimes it's not uncommon to develop fluid around the outside of the lungs with lung cancer called pleural effusion, and this fluid can compress and collapse the lung, and oftentimes draining the fluid will significantly help with shortness of breath and symptoms. But unfortunately with cancer, the fluid many times comes back, and you need some more advanced things to do to kind of keep the person breathing well and keep them healthy and feeling well throughout the day. And so some of the more advanced things we do, one of which is placing a small indwelling catheter that it's flexible and it's soft and it goes under the skin, and it allows the patient and their family to drain at home so they don't have to keep coming in and out for doctor's appointments. Another thing would be to put some medicine into that space around the outside of the lungs called pleurodesis to help close the space so fluid cannot develop in there. Really our focus is to keep the person breathing as well and as good as they can, so not only do they feel better, but I think they tolerate their treatment better as well throughout that process. And then another thing that we do as interventional pulmonologists is deal with airway obstructions. And a lot of times tumors can invade the airway, cause blockage, cause obstruction. So we have techniques to go in with bronchoscopies or even something a little more advanced called rigid bronchoscopies, where we go in the airway in a non-surgical manner and open up that tumor with different techniques and sometimes even put airway stents in to help with their breathing.
Yeah.
So they could continue on their treatment and have as good of a functional status as possible. And then finally, some of the treatments out there, especially some of the newer ones, can cause a lot of inflation in the lungs and cause
Immunotherapy in particular.
right,
Yeah.
immunotherapies with pneumonitis and even radiation pneumonitis. So we stay closely involved with regards to that in terms of diagnosis of that, making sure there's not an infection, and also treating and following along to make sure their lungs are as healthy as possible.
And sometimes we get a diagnosis for lung cancer, and maybe we have enough tissue, but for one reason or another, whether it's an outside procurement that happened, we're getting the second opinion on for the tissue, there may not be enough to do certain tests. We may need to retest for mutations. It's up to debate whether we need to retest for PD-L1 or whether PD-L1 will have relevance in the future, and even potentially using tumor mutation burden to guide treatment decisions. Talk to us about how you talk to the patient about that rebiopsy if needed.
So oftentimes a rebiopsy for more tissue comes up as a request from the oncologist or the oncology team. And sometimes it's with regards to their treatment, sometimes it's within the realm of a trial. And I think this is kind of the value of some of these minimally invasive techniques. You always sit down with the patient and it's going through with mutual decision making and informed consent. But I think as a less invasive approach that's relatively safe and outpatient procedure, many of them tend to be okay with going through another biopsy.
Yeah. And Andrea and Andrew touched upon this, from a pathologist perspective, your role in staying involved in the care during the treatment continuum and how you see that unfolding.
Well, we continue to be important when a pleural effusion is drained, for instance. Sometimes it's inflammatory and sometimes it's a malignant effusion.
Yeah.
And so we're making that diagnosis. Often with a large pleural effusion, we'll have plenty of tumor cells, and those can be in a cell block. They can be used for research studies or for repeat testing. So we try to preserve all of that tumor material from any of the procedures, either a repeat biopsy, in order to have that available for future studies that might be needed.
Yeah.
We're also involved sometimes in biopsies to try to look at the etiology of a pleural disease or a lung disease to see whether it's an inflammatory cause or the cancer in a new place, for instance.
So yeah, we have a lot of research trials that are either at our center or coming down the pike that have put the pathologist back front and center because they're mandating rebiopsies upon progression, which is making your life a little more busy. So I think that's important that there's an understanding that while you guys are front and center for the diagnosis, that you stay involved and remain involved throughout the treatment continuum. Well, thank you guys for talking about your continual role in the treatment continuum, not only at the beginning of treatment, but throughout the patient's treatment continuum.